Yeah, thank you. It was a pleasure. It's a pleasure for me to be here and to share with you what we have been doing in the last 5 years. And I want first to thank my implementation research team, where we're working with a large group of people, but this is the core group. And with Dr. Faisal now flying to Nepal, who is playing the role of clinical opinion leader, and Dr. Stone and Dr. Maloney, who is division chief, also a co-investigator in our project. And we have Carmela here, and we have also another research nurse and a clinical research coordinator who are key in this project. Discussion today is going to be about 5 topics. I'm going to talk about background about pediatric asthma. Then I'm going to talk about the implementation of hospital-based interventions that we did at primary children, but to improve long-term asthma care. And then I'm going to show some data on readmissions. And then I'm going to introduce a novel approach that we have developed to support ongoing asthma care in the ambulatory setting. And then I'm going to end up with a new strategy that we're also developing to, it's like a how to personalize asthma care. As you know, the prevalence of asthma, this is the data from CDC, between 2001 and 2009 was about 10% in the US, which is making asthma as one of the most common chronic illness in children. In 2009, there were about 7 million of children with asthma, and half of them had an asthma attack during that year. And asthma also is known about, is one of the cause of loss, missing school in children. And in 2008, there were about 14 million of children missing schools because of asthma. And pediatric asthma also is known about the significant impact on healthcare use and cost. And there are about 21 billion of medical costs related to asthma each year. And in 2007, for example, there were about 640,000 ED visits and about 500,000 hospital admissions in children less than 18 for asthma exacerbation or asthma attack. And this is making asthma the 3rd leading cause of hospitalization also in children less than 15. There are data published in 2000 for hospital discharged for 2006, about 32% of children were discharged for asthma. And what is important also is the readmission rate high in children. For instance, within 6 months of hospitalization, up to 30% of children are coming back to the hospital or emergency department for another asthma attack. And this number can go up to 50% within a year. This problem of recurrent ED and hospital admissions is a serious problem and can account about half of the asthma medical cost. There are several reasons related to readmissions at provider level, patient level, and also healthcare system. At the provider level, it has been published there is a problem of non-compliance with evidence-based preventive measures I'm going to talk about later, because the care right now is mostly acute. The care model right now is focusing mostly on acute management instead of preventive management. And also failure to assess and address asthma triggers. On the patient level, patient also is responsible mostly about awareness of chronic asthma symptoms, and this leading them to not being compliant with asthma therapy because they feel like, oh, I'm okay, but they don't feel the baseline asthma control, symptoms that they have, and also lack of access it is well known. On the healthcare level, it's known about the fragmentation of healthcare, and it has been published about lack of ineffective care transition, like from the hospital to the ED, and which because of this fragmentation and also ineffective care transitions, there are so many delays and also omissions and even inaccuracy of discharge summaries sent to the primary care provider from the hospital. And something that I'm going to emphasize, it has been discussed in the recent guidelines about ongoing monitoring of asthma care or asthma, a patient with asthma when they leave the hospital. But the problem is challenging to do it, how to do it in outside clinical encounters. And this is what I'm going to talk about also today. But overall, because of this, the asthma care has been shown to be suboptimal. It's not only, I'm going to show data from primary children, it's not only at primary children, but around the nation. And because also poor asthma control in an ambulatory setting. For instance, we're doing a study, a pharmacogenomic study, recruiting patients with asthma by coming to the hospital for other problems. When we give them the NIH questionnaire to see if they are well controlled, not well controlled, more than 60% are poorly controlled. It's here in Salt Lake. And how we did to change the care practice at primary children. In 2006, we did a study we use a method called RAND appropriateness method. It's also called modified DEFI technique. It's usually used to come to a consensus. If you have a group of people, they use it also to develop guidelines and rank also the evidence level in the guidelines. We use this method to define 10 quality measures because in 2006 there were only 2 quality measures for pediatric asthma, and there were not enough quality measures. So we have to do a study to develop those quality measures, and we end up with 10 quality measures. What I want to talk about here is the asthma guideline. These are key area of asthma guideline. On the right side is acute management. On the left side is the prevention measures. The asthma guideline now emphasize about not only treating the acute symptoms, but also initiating preventive measures to prevent the next exacerbation. On the acute management, we have like 6 measures. The most important measures are what use of a short-acting beta agonists or relievers, and also the use of systemic corticosteroid. This is to reverse the symptoms. But the other measures, like the first one is mostly about the location of care, the other measures are mostly related to the cost. But the important part here is measures to prevent exacerbations. Studies and after studies showing like for hospitals, providers, even inpatient ambulatory care, very poor, have a poor compliance with these measures. The first one is assessing chronic severity, level of the patient of chronic control. This drive help a provider to decide what kind of preventive medication patient need. And then the asthma education is important. Also having a written action plan for a patient to manage, to be able to manage acute symptoms at when they live at home. And then follow-up care arrangement, because the care should be transitioned, like if it's from the hospital, should be transitioned to the primary care provider. Over here is to manage the chronic. My asthma action plan is like a plan for the patient to, when they have acute exacerbations, how to respond when they are at home, and also when it's time to call the primary care provider or go to the emergency. And then I'm going to talk about the ongoing monitoring of asthma, a patient with asthma when they leave the hospital, which is emphasized in the current guideline. These are the measures that we developed. As you can see, we have the 6 acute measures and the preventive measures. This is primary children compliance in 2005. As you can see, the measures that matters here on the acute management were very good, but measures related to costs, not it was a problem. But the biggest problem that we found is on the preventing another exacerbation. And what to do with this? We implement what we call hospital-based interventions, but with effect in the ambulatory setting. Before I want to talk about the changing paradigm in inpatient asthma care. Right now, the care is mostly reactive. When the patient has acute symptoms, and then go see his primary care provider, go to the ED or hospital, then they treat him without and then send the patient to the primary care provider, and nobody cares, but there is a less focus on preventive measures. And this is leading the asthma care. It's many papers showing like the asthma care is suboptimal. And because of slow translation of evidence to the current clinical practice. And it has been shown like this lifetime takes 15 to 20 years. It's long. And how to do ongoing monitoring of patient when they leave the hospital. I don't know if anyone with asthma has ever had a provider trying to follow them when they leave home without them. Usually they wait for a patient to have a problem and they go see the primary care provider. But for us, and it has been published, like most asthma exacerbations can be prevented. And an ED or hospital admission is a failure, mostly of asthma management. This is why our approach is an asthma hospitalization or ED visit is a new opportunity for us to evaluate the overall asthma care and start preventive measures to prevent future exacerbations. This is what I call implementation research roadmap, as research study from the basic and moving toward use of the information at in the bench. As you say, after the research moved to the from the lab, this is about where you learn and generate evidence, and then the healthcare policy level takes this evidence and develop guidelines. And where the area I'm going to emphasize is here, implementation research or dissemination research is a new area that NIH even giving a lot of money to focus, and ARC also to focus on this area. The goal is to reduce the lag between when the evidence is developed to the time the information is used in routine clinical care. But to do that, there are tools to do that using clinical decision support and then quality measures. This is why we develop quality measures, so we can be able to understand what our baseline compliance and then change our care so we can improve it. These are the two tools. But the problem, there are studies showing like even a successful tool that a tool that has been successful in one setting may not be successful in a different setting. This because of external factors. And implementation research not only focus on decreasing the lifetime, but also studying what are those factors within an organization that facilitate the translation of research to the bench. And the why clinical decision support? Because of explosion of information, and it's difficult to keep up all this information, and so many papers published every day, and it's difficult to keep up with these papers. The problem with the decision support, help someone translate the evidence easily to the care, to the routine care. You don't need, if you have a decision support, you don't need to remember all the papers, all the information published, but it's a helpful tool to help someone translate the evidence to the routine care. These are different kind of how decision support I'd use. It can be care process model, it can be standardized order set, it can be a reminder, expert system, or also patient set management tools that are being emphasized lately. Going back to our key area of asthma guidelines, we implement our care process model so we can facilitate translations of evidence to the routine care. For addressing acute measures, we develop what is called standardized paper-based admit orders. And then addressing preventive measures, we develop standardized paper-based discharge orders and move it to electronic discharge orders, because the electronic also helping to auto-generate discharge summaries to for the primary care provider, and also auto-fax those discharge summaries to the primary care provider. The goal is to facilitate care transition to the primary care provider. And I'm going to talk later about the ongoing monitoring of asthma symptoms. As you can see, the impact after we implement our care process model, this is data in 2010. This measure we have not developed a process to implement it yet. As you can see, there was a significant improvement with all measures, especially the preventive measures. These are what is called these are process measures. This is why we had to look at the impact on outcome, because the process measure is meaningless if there is no association with outcome. We look at our readmission rate. What was the impact on readmission rate? This is mostly the proportion. It's not rate as a standardized way to use it. But as you can see, this is what is called control charts. It is used mostly in quality improvement. You can see like since 2003, our readmission rate was like about 15%, and it has not changed until we implement our care process model, which started in 2008 and end up first quarter of 2009. As you can see, all the points falling below the midline since we implemented. And it's also sustained. This is the first study to show a sustained, because many studies will show one point in time comparing pre and post, something like this, but this is a sustained since 2009. And we didn't stop here. We compare our readmission rate to all children's hospitals in the US. These are like 32 hospitals. The person who sent me the data made a mistake here. But as you can see, in 2008, primary children we were about like the 10th. In readmission rate, we were about 20%. But before I talk about the change, this is also telling you something, it's called variation in care, high variation in care. Although readmission is maybe affected by multiple factors, but if you are a patient with asthma hospitalized here, like within 6 months, patients here, 40% of them come back to the hospital for the same problem. But when you are here, you have like almost like 13%. This is huge variation. What is going on here and what is going on here is something that we need to understand. But the best thing here with our intervention, in 2009 we were like 6, and 2010 we were the first hospital now with the lowest readmission rate in the nation. And we, is each bar a different hospital? Yes. So that's not over time. Yeah, each hospital. As you can see, we cut our readmission rate here in half, and we are at the top. And we're going to maintain, and we are going to decrease even this further. And what we do with this, because this is a successful, something that is a story to tell, but we didn't just tell, but we apply for a grant so we can disseminate this success to other facilities. We start first at Intermountain level. We're implementing the care process model at 8 Intermountain facilities. They are spread within Utah. The goal is coming back to the implementation roadmap again, because we want to understand what are those external factors within organization. So if we want to implement the care process model elsewhere, we can, because we're going to publish implementation manual, so people can know what are the tools they need to have to be able to replicate what we did. This is kind of messy, but it's easy to understand. This is our team. We have developed an implementation package. We're using a channel, which is a pediatric clinical program. This is the same picture we're going to use at the national level. We can use ARC, we can use the Joint Commission as a channel to reach hospitals. And within hospital, our model is to find opinion leader. We have the main opinion leader. We have opinion leader at each hospital. As you see, we're moving from academic environment to a community environment. Organization within hospital is different. We have to learn what are those organizations. But what is important here, what are those barriers, what are those facilitators that can help us achieve the same success? What are those what is called cost-cutting factors that each hospital should have to be able to have the same success? And we're not just going to assess those Intermountain facilities. As you can still remember those hospitals across the nation, we're going to send a survey also Because who are those hospitals doing well and who are those who are not doing well? What are those commonality between those doing well and those not doing well? Because we want to understand and then publish an implementation package for hospital to be able to replicate our success. Yeah, I want to say here, this is the first study to show a sustained and significant reduction in readmission. And also this study is showing evidence that intervention can be initiated at the hospital level, but to have a long-term impact. You don't need just to focus on ambulatory setting, but everywhere, ambulatory and also inpatient. And also we want to learn with the successful implementation of the same care process model at other intermountain facilities, and also studying other children's hospital. We're gonna understand what are those generalizable factors that can each hospital can be able to use to be successful. But the problem here, I present mostly, I emphasize on the acute management and preventive management. I didn't talk about the ongoing monitoring. This is what I'm going to talk now. I'm going to introduce now a novel approach that we introduced to support ongoing asthma care. This is the big impact that we're going to have in the next 5 years. This is our biggest excitement. It's what I'm calling also changing the asthma paradigm from reactive acute care to ongoing proactive management. Coming back to our key area for asthma guideline, this is the area where we're going to talk about ongoing monitoring with the monitoring system that we have developed. Why we did it? Because you know that chronic asthma symptoms changes over time, and recent guidelines is recommending to emphasize on monitoring of asthma on an ongoing basis, because by monitoring, patient can be able will be more aware of the asthma symptoms, and also will seek care sooner. And at the provider level, can give them information to adjust asthma therapy sooner as we're waiting. But the problem how to do it, because very few people have done it. How to do it in where we are in the hospital, we want to have an impact in the outpatient system. With what I talk about, the broken system within the hospital system, and between the hospital and also ambulatory system, and also lack of resources and incentive for care providers to do that. We developed a tool that we call the asthma tracker or asthma symptom tracker. It's a new tool using first paper-based to improve asthma control in the ambulatory setting. The tool targets both patients and the parent, because we're dealing mostly with children here, and it can be also used for adults, because we're going to test it in adults very soon. And the primary care provider and the patient is to engage them in self-monitoring and weekly self-monitoring, and also trying to go see the primary care provider sooner. It's giving them information so they can seek care sooner. And the primary care provider level is to see the pattern of change of asthma symptoms so they can adjust asthma medication sooner on, and also understand if the asthma therapy is effective. And the tool has two main areas, the questionnaire and also charts for decision support. But the questionnaire, we borrowed the questionnaire from an existing tool which is called Asthma Control Test. It's a standardized tool, has been used for years in asthma. But the problem, the tool is used in intermittent basis. When the patient goes see the primary care provider, then if the primary care provider remembers, then use it to assess the asthma control. But it's mostly average over the past month. And usually, right now, no, the tool does engage patient to do it on a weekly basis. We contact the person who developed the tool. If you talk about asthma in the nation, Michael Schatt is known. Dr. Michael Schatt is an allergist. And we contact him so we can modify his tool to make it a weekly tool. This is what we did. He's also excited, and he has joined our team. We're writing a grant together, which is going to the NIH next month, in January. We changed it to a weekly assessment. And then also we add information here so we can get some of how they are using the asthma medication, and also if they have a hospital visit or a physician visit. This is how the tool looks like. On the top part here, it's the questionnaire, which we give a patient like a packet of a questionnaire. They answer each question and calculate the total score and plot it on the chart. Every day. Over here, there are decisions based on where the patient is on the score. And on top here, these are just instructions, and this will related to asthma. What written action plan. This is mostly for management of acute, but this is for chronic. As you can see, normal pattern is patient leaving the hospital in the yellow. They start in the yellow zone or red zone, and then improves, and then go to the green zone where they should be. Green zone is well-controlled area, and not well-controlled and poorly controlled area. The goal is to stay in the yellow, the green zone. As you can see, we're finding interesting pattern that we're going to talk soon. But since we changed the tool to a weekly assessment, we have to validate the tool. And also the existing tool has been validated on children 6, 11, and then 12, 18. But we wanted the tool we can use everyone, 2 to 18, even adult. We don't care about one point in time. What we care is the trend over time. And we can use either patients or we can use a proxy. Because it has been shown like parents usually underestimate what their children's asthma symptoms. But we can keep the same bias if you look at over time. Having the same bias looking at the trend, you can still capture an improvement or deterioration of asthma symptoms. This is to, we assess it with another tool which is used mostly asthma, control questionnaire. It's a weekly tool, but mostly used in research. Less hospital using it in patient care. As you can see, because the first month when the patient leaves the hospital, they do the first survey at the hospital with Camilla F, and then they do both surveys, the asthma control, or our weekly asthma control test, and also the asthma control questionnaire. Then we follow them for the first month. Every week they do both surveys, and then they stop the first week. The first month, excuse me, they keep using only the tool. And this is the correlation between our tool and then the asthma control questionnaire. But to be able to do that, we have to standardize the score, because the asthma control questionnaire, the scale is 0 to 6. Our tool is 5 to 25. We have to change the scale to 0 to 100 so we can standardize and then do the correlation. As you see, it's almost a perfect correlation between the two. And we look also what is called responsiveness of the tool. If the other tool showing like the patient is improving, are we capturing with our new tool also is the patient is improving? Ours is the red and the other one is in the blue. As you can see, if this with the standardized score, if there is an improvement, where there is an improvement, there is a drop, there is also a drop. We also look what is called this discriminant validity, because you are expecting that patients who report that they are poorly controlled asthma, they will be using more quick relievers because of the asthma is poorly controlled. And this is also what we found. If in our tool, patients who are classified as a poorly controlled asthma, they are using, also 80% of them are using quick relievers, or example albuterol, and those not classified as those classified as a well-controlled asthma, they are almost not using the quick reliever. This is now exciting. What can we learn now with this new data? Because in the current care now is a provider seeing a patient one point in time, but I don't see the pattern of care of symptoms when patients leave the hospital, even primary care providers or hospitals. But this is something, because when patients are hospitalized, we give them also the standardized tool for NIH to classify them if they are intermittent or persistent asthma. Intermittent is mean asthma, they are almost most of the time well, and once in a while they have some exacerbations. But persistent is they have asthma exacerbation most of the time. But this is like a pattern that we're learning. Like this is for, we look at the pattern, we look also how they are classified. Now this is an example of an intermittent patient leaving the hospital. We're in a poorly controlled area, and then stay flat on top, optimal level for all the time. Over here, this is a different kind of intermittent asthma. And we even thinking, is the NIH tool better than seeing this one? Because over here I can see who is a really intermittent patient, and this one is even questionable because the patient is quite classified as an intermittent, but stay like almost 2 months to reach the optimal level. Yeah, these are new questions that we're thinking with this information. These are example of two persistent asthma patients. They leave the hospital usually in the red zone and then move to the green zone, and then they drop. They stay, they go back up, they drop. This drop here and this drop here is different. This one I can say maybe there is a trigger, not an existing trigger. Maybe the patient was exposed one time to a trigger, then come back here. But over here, it may be something that is persisting, maybe at home. It may be also the treatment is not effective. These are information that nobody can have this kind of information. With this tool, we can be able to understand asthma better. This is a different one. This is very important because this is what the patients, when they go to see the primary care provider, they bring did you bring, do you have a copy of the asthma tracker? Paper-based, okay. Yeah, they bring this also chart so the primary care provider see. If the primary care provider sees this patient, for example, this is a patient with asthma management is not good. Is it a problem at home? Because this is persisting. And this will tell the provider it's time to look at the asthma management, to go talk about with the patient what is going on at home. And it's also predicting like there will be a severe exacerbation. This is what happened here. Because usually before they have a severe exacerbation, they will struggle for a long time, then they have a severe exacerbation. We can capture this information sooner so management can change, so to avoid patient coming back to the hospital. And also, this is also a different one with the new pattern of asthma control that you're seeing here, patient going up optimal, dropping, going up optimal, dropping. But we want to understand what is going on here. Example, exercise, maybe trigger, maybe what is in the air quality. The air is bad, maybe pollen count is high, maybe it's a viral season. That's why we're moving now to the next step. Before I talk about the next step, we did also patient perception, what a parent perception. When they do 3 months within the survey, we send them a long survey. Within the studies, we will send them a survey so we can see what they're thinking about the tool. And so far, we have like we sent to 53 patients, we have like 45 respond. We're still reminding them to do that. But overall, there is a very good, they like it. They like it. The kid also, we have some kids, they do it by themselves, like 12 years old. They like it also. And as you can see here, we ask them also if they want to continue in the future because we're trying in the future to move them to the electronic version. And 83% of them say yes. And these are the reasons that they're providing about why they want to continue using. This is interesting, and they love it. And it's helping them, educate them how to manage the asthma better, and empower patients also and parents how to manage asthma better and to be aware of asthma symptoms, and help primary care providers also. We have not done the survey of primary care providers yet. And these are also reasons for people who say they don't want to use it in the future. But mostly this person has lost, I don't know if Camila, you have sent in the parent, another, yeah, okay, okay. And this one, although they said that no, because it was infection induced, but still positive, what they're saying. And these people didn't talk about, I look at them, 2 Medicaid patients, and I look at the income level was like 25,000, something like that. I don't know if it relates to poor education, relate to something, I don't know. But we're not gonna know that very soon with as we're getting more surveys back. This is a simple and easy to use tool developed for monitoring patients outside clinical encounters. And this is changing also care from intermittent acute management to ongoing monitoring and self-management. As you know, self-management, one of the grants that we're writing in January is about self-management because it's an area that NIH is trying to push a lot for chronic disease. And this tool also helping us discover new patterns of how to understand asthma better. And also can be used in a broad population. Now we're using it for patients admitted to the hospital, but in the near future, we're going to go to schools. We're going to go open it to primary care providers so they can enroll their patients and they can be able to monitor the asthma patient better. And this tool can be used also. You can use it in diabetes. You can use it in hypertension. Every time that you need to monitor a patient regularly, and we can use it also in adult. Now I'm going to move to our new strategy, what we're planning for the next 5 years, how to personalize asthma care, and I'm going to end up here. As I said, the asthma symptoms changes over time, and due to many factors can be what kind of therapy patient is receiving, the compliance with asthma medication, and also the asthma itself, what kind of severity level, and also patient susceptibility to environmental triggers. But this is where I'm going to emphasize here mostly. This is our first step. But the problem is, it's been shown like mostly patients do not recognize their asthma triggers. And since they don't recognize, they don't know how to avoid their asthma triggers. And there are also studies showing like primary care providers, or not only primary care providers, there is a lack of compliance about assessing and addressing asthma triggers. And what we want to do is, as you're seeing those patterns of increase, decrease, increase, decrease, increase, decrease, we believe like someone using it regularly, we can understand the pattern well, and then we can align this information with changes in asthma triggers. We're going to start with air quality, which I'm going to talk about later. And then we're going to talk also, use also pollen count, temperature, and humidity. And then we're going to move to home environment to see what are those triggers at home and try to align and patients within so we can understand it better. But the problem, there are limitations on the paper base. We don't have no active real time. And you cannot store data for a long time because it's limited to 6 months, although we can send another tool, another paper to the patient. And this is why we have developed the web-based version. Yeah, this is the tool. It's we are done with the patient user interface. We're moving to the provider interface. The tool will be able, like this is like a patient already registered in to the system. The first thing that the patient will see is a reminder when was the last time they did the survey. And then we're going to have some gaming also for kids to be able, but before they go to the user or the feature, they have to answer the questionnaire first. And then the patient can close it. And then the same survey we have, the 5 questions, for example, a patient saying, oh, I'm good, everything good. It's been and then go to the next page. This is the bottom part of the survey, the paper base, capturing information. And also who respond to the survey, the parents or the patient. We want to capture how many times they're using a controller a week, like how many days. This is for quick oral steroid. And then they will have to answer the other question about other medication they're using, and if they have seen or have an exacerbation during that time, during the past week. And then they click, this date is going to go away. It's going to be automated very soon. Or there is a reminder, like if you forget to answer some questions. And the same color-coded decision now will come and pop up for the patient, where they are, and then we remind them the score, and then what they should do. And then they can close it. And the best thing now, you have a long-term pattern. You can scroll. And the same view, the provider can see the same view. And also you can change, go like to 6 months and see the pattern of change over time. This is unique data that nobody has now, and it's going to change the way asthma is being managed. We're going to have a alerting system to the primary care provider. Let me talk about this tool. We call it e-ASTR, electronic asthma symptom tracking and exacerbation response application to address both primary patients and then the primary care provider, and also to add active feedback. It's not just passive feedback now, active feedback, and also to okay. Yeah, the advantage of this tool is active feedback. The patient can access it anytime, anywhere, and then you can have a unlimited data storage. It's good to see long-term pattern and understand asthma care better. And it's providing new opportunities to study asthma well in a different way and to link it to triggers, because if you can be able to link asthma to trigger, you can personalize asthma care based on individual patient's response to the trigger. Yeah, having able to identify a subgroup of patients who are susceptible to trigger is a better way to manage asthma care than just treating with and as you see the patient was like flat. Maybe there is something at home. Regardless of the treatment, the patient is still not improving. This is my last slide. It's a little bit complicated, but this is what our goal now and also in the next 5 years. We have developed a web-based tool the patient can access anywhere. Data is stored. We working with University of Utah, Office of Science Computing something. They have a HIPAA compliance server, and this data, we have a report generator which will create the same graph, and then we have rules within the graph. We're going to even add some rules even when the patient is improving, just to encourage, oh, you're doing great, something like that. And within the rules, the patient dropping is going to send an email to the primary care provider. We're going to enroll primary care providers. And it's going to send an email also to the patient or the parents. We're going to add also text messaging and also interaction with Facebook, because now kids are mostly in Facebook area. And then with the email, which may come with a link, it depends on hospital, like Intermountain may have it within the EMR, and all the other hospital may be a link, then you click, then you go enter your password, then you can see your patient, because we're going to have a relation between provider and patient. And then they can go see the primary care, the information within the trend for the patient, or contact the patients to address the problem. We have at least 2 groups contacting us so we can develop the mobile application. But we may go with the NIH or within our department to develop a mobile application. And something we have already managed to develop what is called automated phone with IVR, interactive phone messaging system, which the patient will receive the call, or the patient can decide when they want to receive the call or call the system. And the same questionnaire will be in a voice, and then choose the response, and then recommendation will come also in a voice. And then every month they will receive a paper-based report. And as we're storing all this data, we're going to bring the allergy data. We're going to bring something that I didn't put here, pharmacy data. And we're going to bring also what is home trigger. We have a survey, assessment survey that they will be doing when they answer the questionnaire. That will be able to also to assess the asthma inventory trigger. And also the air quality. We're emphasizing on PM 2.5 and ozone first, and then also humidity, temperature. And then we have a group working on genomic with air quality. We're gonna team up like the next year or next two years to write a grant with them, so we can understand the pattern not only at the symptoms level but at the genomic level. And then we have also another colleague of mine working on a viral or the data with a germ watch. You know that with PAIR. Yeah, we're going to link it also to see, because viral trigger is also one of the main important trigger in asthma. And the goal is Who are you as a patient with asthma? What are your triggers? What is making you better? What is making you worse? This is where we're moving. Yeah, as these are my advisory committee, and these are people well known, and yes, and we meet with them like twice a year, and discussing this proposal, and we're going to meet with Wayne, who is involved in primary care at the mountain, so to roll out the paper-based tool to the adult, and then I acknowledge also my two grants with the ARC, which has helped us initiate this project.